So hello, everyone. Welcome to our webinar today on multi-drug-resistant tuberculosis. My name is Nancy Bedingfield, and I'm a project manager with the National Collaborating Center for Infectious Diseases, or NCCID. And as some of you may know, the National Collaborating Center for Infectious Diseases is an organization which works to support collaboration between public health practitioners and to help public health practitioners use the best possible evidence to tackle challenging issues in infectious diseases. NCCID is one of 6 national collaborating centers funded by the Public Health Agency of Canada. Each national collaborating center is located in a different region of the country and focuses on different aspects of public health. And if you'd like to learn more about the different NCCs, you can go to the Public Health Agency of Canada website. The NCCID is hosted at the University of Manitoba, which is located in Winnipeg, which is Treaty 1 territory. And Treaty 1 territory are the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, as well as the homeland of the Métis Nation. However, just to reflect the diversity and complexity of our new online world, Dr. Edwards and I are actually joining you from Calgary, which sits on Treaty 7 lands and is at the connection of the Bow and Elbow River, also known as Mohkinstsis in the Blackfoot language. And we recognize the lands of the First Nations people that we are fortunate enough to live and work in order to acknowledge the ongoing need for truth and to state our continued commitment to reconciliation. And so, as you know, our webinar today will be focused on multi-drug-resistant tuberculosis epidemiology and challenges in the treatment and management of multi-drug-resistant tuberculosis. And our eminent leader in our conversation today will be Dr. Brett Edwards. And I'll tell you a little bit more about Dr. Edwards. He is a clinician and researcher in the Division of Infectious Diseases at the University of Calgary. Dr. Edwards completed subspecialty medical training in infectious diseases before obtaining a clinical and research fellowship in mycobacterial disease at the University of Toronto and at the West Park Health Centre in Toronto. He obtained further training in TB, including drug-resistant TB at Groote Schuur Hospital, which is located in Cape Town, South Africa. And the Groote Schuur Hospital sees some of the highest rates of multi-drug-resistant TB in the world. He currently works at Calgary Tuberculosis Services, a clinic which works directly with public health in Alberta. And in addition to his work in TB, Dr. Edwards also works with the clinical infectious diseases and the non-tuberculosis mycobacterial program at the University of Calgary. So thank you, Brett, for joining us today. Before I turn the microphone over to Dr. Edwards, I'm just going to mention a few housekeeping items to help our webinar run a bit more smoothly. Finally, it of course really helps our work when we receive feedback from you, who after all are an intended audience for this work. So we'd really love to know what you thought of the webinar today, how well it met your needs, and what we could do better for future webinars. So at the close of the webinar today, you'll receive a link to an evaluation, and we really ask you, if you can, to take a moment or two. We've designed the evaluation to be very brief. So just take a moment or two to complete that evaluation, and it will really help us to improve our work going forward. So all that being said, I'm going to turn the microphone over to Dr. Edwards and thank him in advance for sharing his time and experience with us today.
Thanks, Nancy. I'll just get things loaded up here. You're seeing everything okay there, Nancy? Perfect. Okay, well, thanks very much, everyone, for joining, and thanks, Nancy, for that kind and generous introduction, and for the invitation to speak today and share some thoughts and data around multi-drug-resistant TB in Canada as it relates to a public health perspective. For this talk, I have no disclosures to bring forth. And as alluded to, I would like to first take the opportunity to acknowledge that I'm presenting from the traditional and current territories of the people of the Treaty 7 region in southern Alberta. And this includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Wesley First Nations. And the city of Calgary is also home to the Métis Nation of Alberta, Region 3. And so, as alluded to in the introduction and some of the documents prior to this talk, these are some of the objectives that we hope to bring across in the discussion today, and happy to answer some questions beyond afterwards. Really, this is designed, my hope, to be a brief clinical introduction to multi-drug-resistant TB, or MDR TB, and hopefully not too in-depth, but to provide some clinical context to the patients that many of you are seeing regularly and who are dealing with the challenges of TB, and to highlight why specifically multi-drug-resistant TB, it poses a particular challenge. For many of you, a lot of this will be old information and well-known information, but it's hopefully to get us all on the same starting point. I will start with some basic background on tuberculosis in general, because the principles are very much the same for MDR, but are amplified in certain ways in certain areas that I'll highlight. And we'll discuss through that some challenges for public health. And yet, I hope to highlight really some of the exciting times that we're in right now in terms of TB treatment for MDR TB. And the active evolution in that treatment that is currently underway. And then also hope to increase some awareness of potential solutions to reduce MDR TB incidence in Canada, and ways to support people affected and their families. This third objective, I personally think, is the most challenging, certainly something I don't have all the answers to, and something that many of you are very much actively involved with in exploring those solutions on a day-to-day basis. I would like to highlight that if you are more of the read on your own and would like to delve a bit further, and as alluded to by Nancy in the introduction, this document here is very, very exceptionally well done. It's concise, it's well written and factual, with direct links to information from the World Health Organization, CDC, and Canadian TB standards. So highly recommended if you like to learn that way. And so to orient ourselves, we'll start with some definitions for this talk, just to get us all on the same starting point. So drug-susceptible TB, something that we most commonly see or encounter in Canada, refers to susceptibility to what have been defined as our four first-line drug therapy agents, most importantly isoniazid and rifampin, along with ethambutol and pyrazinamide. And drug susceptibility TB, that definition really highlights the importance of isoniazid and rifampin, two drugs that were developed in the 50s and 60s respectively, and this combination here that we've been using now for over 4 decades. And yet, despite the challenges that are recognized and encountered in TB treatment, comparatively, isoniazid and rifampin are quite safe and efficacious medications. Multi-drug-resistant TB, on the other hand, refers to resistance to those two important first-line agents, isoniazid and rifampin. So by definition, or by description, it's really a pragmatic definition. So MDR TB, the symptoms are the same. How it develops is the same. Infectiousness is felt to be the same. But the fact that there's a definition that emphasizes isoniazid and rifampin resistance indicates the implications that resistance to those two medications has, and we'll delve into that a little bit. We won't talk too much about something called extensively drug-resistant TB. It's fairly uncommon in Canada, but just to highlight that it is a subtype of multi-drug-resistant TB with further resistance to oral medications that are fairly important in the treatment. And so at a baseline, it's important to highlight, and something that I think you all know very well, that TB is incredibly difficult to treat. It's a beast of an infection, very different from any standard pneumonia, that we can generally cure in a 7-day period. And this is for a variety of reasons related to its resistance and both intrinsic and capabilities in developing resistance. So at a start point, antibiotics that might be used for other pathogens really struggle to enter the cell wall or the barrier provided by tuberculosis. And even once they are able to enter within there's further intrinsic mechanisms that help fight off that assault, including the bacterium having mutated binding sites. It possesses proteins or enzymes that then can degrade those antibiotics or simply pump them right back out, rendering them ineffective. And in those antibiotics that the germ is not naturally resistant to, it's well recognized that inadequate or too few or inappropriate treatment allows mutation or propagation of mutated forms of tuberculosis quite effectively. And so human intervention accelerates resistance, and that will be an important component of our talk today. And this acceleration of resistance through human intervention is what creates multi-drug-resistant TB. TB in general has an estimated mortality of roughly 50% if disease is untreated. So you combine these challenges with its baseline resistance, its difficulty in treating, and then compound with the airborne spread, making it one of the most highly infectious and transmissible germs recognized in the world. It's a very big deal for public health. And because of this absolute necessity for treatment adherence and isolation for multi-drug-resistant TB, because of those challenges, we really ask a great deal of our patients in the name of public health. And so where does multi-drug-resistant TB come from? Well, it can develop in someone who receives incomplete or inappropriate treatment, or can be transmitted from someone who already has it. Human intervention amplifies resistance in any infection, but this is more easily visible with tuberculosis because it's a reportable disease, and so something that's easier to track. This inappropriate treatment is more often due worldwide to availability of diagnostics and treatment modalities rather than the availability of knowledge. Still too commonly, empiric treatment or best guess treatment based on things like smear microscopy or seeing the germ under the microscope, but without being able to confirm it in a culture and thereby test it for which drugs it's most susceptible to, is one of the ways that inappropriate treatment can propagate MDR TB. We try to avoid this type of treatment as much as possible, and so there's been a slow increase worldwide in culture confirmation of tuberculosis globally in the past 2 decades, and yet still in 2021, only about 2/3 of cases were confirmed on culture. And so while this is increasing, the rates of culture confirmation of TB are still lowest in low and middle income countries. Further beyond that treatment component is challenges with non-adherence, inadequate absorption of the medications that are provided, or inadequate or incomplete support to help navigate the challenges of completing a long antibiotic course. All can further propagate MDR TB. And all of these in some way or another are linked to deficiencies in social supports, healthcare access, and limitations in foreign investment. So the fact that observational studies oftentimes find higher treatment success rates in high income countries compared to what is published in large meta-analysis data, it certainly is not due to better clinical skill. It's much more related to an improved network of laboratory resources and social support. And so why does this matter? Multi-drug-resistant TB, yeah, it sounds terrible, but what is the practical challenge with that? Well, as many of you know, TB itself is already very challenging, and MDR TB is exponentially so. As we talked about, the symptoms, infectiousness, and natural trajectory are no different, but it's that treatment management component piece that is so difficult to navigate. And a lot of this revolves around the time of treatment, the time exposed to potential toxicities, the time of isolation. So the time of TB treatment, for drug-susceptible TB, most commonly we would treat for a period of about 6 months. Multiply that by 3 or 4, where current guidelines have advocated for at least 18 to 24 months of treatment, most recently, and historically even longer than that. This has been through the use of less effective medications. Those medications also associated with higher toxicity to peripheral nerves and brain nerves and the liver, gastrointestinal system, and a longer exposure to those toxicities, or more opportunity or more time for those toxicities to develop. Further complicating that is medications that are less effective than our first-line agents. And so you combine all of those above factors, and the treatment success of MDR TB is far, far lower. On average, estimated treatment success has been around the 50 to 60% range, compared with at least 85% for drug-susceptible TB. Again, because of the challenges of treatment and management, this has led to our policies for longer isolation periods for MDR TB, longer contact tracing for household and close contacts, It's associated with a higher cost of treatment and care, increased associations with mental health, including increased depression and stigma. And then it's very well recognized that antimicrobial resistance is a global challenge that the world is facing right now, and tuberculosis is very much not immune to that. And further, why it matters is this social aspect of tuberculosis that is compounded with multi-drug-resistant TB. The things that promote TB transmission are risk factors for MDR TB development. And so we'll unpack that a bit. This quote here is from Dr. Teresa Tam in 2018 in her Spotlight for Eliminating TB. And it really, I think, very nicely highlights the strong socioeconomic gradient that exists with tuberculosis. If we look at this graph here on the bottom left, it's well recognized that the rates of TB really peaked throughout different parts of Europe and Asia in the 1700s and 1800s at different times, and believed really related to the periods when those regions were going through industrialization and urbanization. And with that came along population density, crowding, and poor nutritional status. And yet, in figure 2 that we can see there, even before the very first tuberculosis medication, streptomycin, was developed in the 1940s, we were already seeing a very clear decline in TB incidence and death. And it's believed this is most directly related to economic growth, poverty reduction, improved living conditions, improved nutrition, and the recognition of transmissibility. What's not shown on this graph and thereafter in the 1980s and 90s was massive increases in incidence of tuberculosis in certain parts of the world. So in Eastern Europe, with the fall of the Soviet Union, there was huge decline in living conditions, decline in accessibility to healthcare or reliable healthcare, increased alcohol misuse and overcrowding, and led to large increases in TB in that region, and has led to some of the current challenges with multi-drug resistance there. Similarly, in sub-Saharan Africa, with the HIV epidemic and associated undernutrition, again, large increases in tuberculosis incidence that continue to be a challenge there to this day. And so there remains a very reliable correlation between incidence of tuberculosis and a country's GDP and undernutrition. So these same social risk factors of extreme poverty, food insecurity, malnutrition, overcrowding, all promote multi-drug resistant TB. And amongst other things, I think it highlights the significant ongoing need for funding. If we look at the epidemiology of resistant tuberculosis, overall, in terms of TB incidence, we have seen a steady decline ongoing in TB incidence, and we've seen stability in drug-resistant TB, especially through the early to mid 2000s and through 2015 to 2020. And then in 2021, there was recognized increased infections, including rifampin-resistant TB, which is a surrogate of multi-drug resistant TB, an increase of about 3.5% from the year prior. And only about a third of those cases had received proper treatment. And there is some indication that we are seeing some ongoing increase in case numbers worldwide. A lot of this is directly related to the COVID pandemic. So COVID TB combination, or a syndemic, as some have referred to, is certainly a talk all on its own. But it truly is the epitome of piling on, further disproportionately impacting those who are already at a massive social detriment. It impacted those who were formerly diagnosed and treated, and is going to leave a legacy of increased TB, including drug-resistant TB increases for at least a few years. We've also seen, we also well recognize the importance of treatment or previous treatment in the rates of multi-drug resistant TB. So most recent estimates place MDR TB globally on about 3.5% to 4% of all new cases that are encountered, but about 18 to 19 or 20% of retreatment cases worldwide. This latter stat really emphasizing that human intervention is will promote resistance, especially if it's incomplete. Some of the largest proportions of multi-drug resistant TB in previously treated cases that we see come from certain parts of Russia, Eastern Europe, and Asia, where rates of multi-drug resistant TB in previously treated exceed 50%. So again, those same risk factors for TB overlap with resistance and the known social determinants of health, things like malnourishment, HIV, alcohol misuse, smoking, and potentially diabetes. And the epidemiology of MDR TB is part of why this poses a key challenge here in Canada as well. So if we look at TB drug resistance in Canada, it represents about 1 in 10 cases, or shall I say 1 in 10 cases of all new TB that are seen here in Canada has some form of resistance roughly. Overall, our rates of MDR TB are approximately 1.5% of all cases, but that's disproportionately represented by, in the foreign-born population, approximately 95% of the cases that are seen. MDR TB is fairly uncommon in the Canadian-born and quite uncommon in Canadian-born Indigenous. And so how do we detect it? How do we know that a case is drug resistant? There's really 2 main mechanisms to achieve that. So one of these is through something called phenotypic drug testing, where we identify a new case and we're able to ideally grow TB in the laboratory, and then we incubate that TB with some antibiotics to see what works best. This is our gold standard of diagnostic testing. It is recommended for all cases of tuberculosis because of the reliability for drug susceptibility. It's slow and can take a couple weeks to get those results. Alternatively, there's been newer technology, which we refer to as molecular or sometimes genotypic drug susceptibility testing. And what this does is aim to identify DNA or molecular material, nucleic acid material from the TB germ, and then to test regions of that DNA for known locations for drug resistance. This is quite a fast modality. And has been shown that it can shorten time to appropriate therapy as the results can be available within a day of testing. And it's been recommended to be available for all new cases of tuberculosis in Canada. Unfortunately, access, it's quite an expensive technology, and it's not ubiquitous or at this point, not even near ubiquitous across Canada. The most common modality that you'll hear is something called Gene Expert. But other brands are out there and with different techniques. And so the risk factors for drug resistance, we've kind of alluded to these a little bit already in some of the slides, but internationally, it's well recognized that multidimensional poverty in meta-analysis has shown increased rates of MDR TB, including things like low income, malnutrition, education, and social support, inadequate housing, overcrowding, and race and ethnicity, more likely related to some of those above factors. There is likely some contribution or combination from alcohol misuse and smoking as well. If we look at Canada, the rates or risk factors for drug resistance are more directly related to prior treatment, foreign birth, arrival from a country where there's high rates of recognized drug resistance, recent arrival from to Canada, and HIV positivity and potentially diabetes. And so the rates of MDR TB in Canada seem to be directly related to prior treatment and foreign birth. And so let's unpack that a little bit. So it's a very elegant study that was spearheaded by a couple of TB experts at the University of Alberta, Dr. Long and Dr. Lau. And it was really to explore the rationale of increased multi-drug resistant TB in Canada. Over the past several decades, Canada has shifted immigration patterns from countries where there was a fairly low incidence of tuberculosis to countries with much higher incidence of TB, including areas in Africa and Asia. And also since 2000, we've seen roughly an increase of approximately 100,000 migrants per year. And there's been a similar trend in Alberta where the proportion of foreign-born population has increased over the past 2 decades. And so with that increase, does that increase in immigration on its own explain MDR in Canada, or are there alternative causes, meaning is there more MDR overseas, or is there more local transmission? And to make really a long story short, how the study, they looked at the rates of multi-drug resistant TB in kind of a first 2-decade period from 1982 to 2001, and then the latter half of the study from 2002 to 2019. And there was a 5.5-fold increase in multi-drug resistance from high MDR countries between that latter period, with an increase of about 85% occurring in that latter period. And so by estimating the number of cases of MDR in that latter period that you'd expect based on the initial numbers, as well as contact tracing and some DNA fingerprinting techniques, it was seen that there was no locally acquired cases, and only about a third of those of that increase could be attributed to increased immigration rates, and therefore 2/3 of that increase must be directly or indirectly related to increased MDR in those high burden countries where people were arriving from. And so I think, certainly an important take home from this study is really this idea that no one or no country is an island. We're an international community with blurred borders. We travel, we move, we congregate. COVID-19 was a clear evidence of that. And the idea that an infection is someone else's problem and not something that's on our doorstep is foolhardy. And so, MDR, as we've highlighted, is certainly a challenge for many reasons, and particular challenges that are experienced here in Canada are a few. There's delayed diagnosis, not specific to MDR TB, but TB in general. Because it's a relatively infrequent infection compared to worldwide rates, there can be lack of familiarity based on where an individual is residing, and this can lead to delayed recognition of the diagnosis before connection with a TB service and provision of advice and treatment. There's also been incomplete access to molecular testing, which can expedite that diagnosis and expedite the provision of appropriate therapy. There's also been delays in reporting or surveillance of rates of TB and MDR TB. So that can delay the recognition of the landscape of infection across the country for clinicians and TB programs. There's delays in starting appropriate treatment, again, because of delays in that diagnosis, but also delays in acquiring medications, which we'll talk a little bit. And then we don't have a coordinated or direct connection with regional TB services or experts, which in some regions is not a huge deal, but for others, especially in more remote settings, can pose challenges as well, including delays in access to that expertise, knowing who is using what drugs and what drugs are available and how to access them. Some of these latter points are something that's quite effectively done in the United States. We won't delve too much into treatment, but it's important, I think, to give some context to the treatment that is provided for multi-drug-resistant TB in Canada. Also important to recognize that treatment varies worldwide based on drug availability and diagnostic availability. But in short, in Canada, our current regimen is a combination of 5 different medications, generally used for at least 18 to 20 months. And unfortunately, these are not medications that can simply just be pulled off of the drugstore shelf. 3 of these 5 medications require special approval from Health Canada, and thereafter, those 3 drugs need to be approved and supplied by a manufacturer at their discretion, which leads to the potential concern of unreliability in that pipeline. This is an involved process, even when there's lots of support. So especially in remote or uncommon locations for infection, without pharmacy support, this can be a big challenge and lead to delays in initiation of therapy. Important to differentiate, however, that this current regimen is a big step forward from 5 to 7 years ago, where treatment was still very much revolving around injectable-based medication, which comes with a lot of its own challenges. I alluded to this in the introduction, but we're very much in an exciting time for TB treatment, for multi-drug-resistant TB in the world, where in the past year we've had 3 major randomized controlled trials highlight the potential utility and benefit of shorter all oral based regimens based on some newly developed medications that have come about in the past number of years. And this includes a combination of 3 or 4 oral medications used for a period of 6 to 9 months. And this potential change has the potential to be transformative in multi-drug-resistant TB in this march to shorten therapy. And as of 2022, this has become a potential recommended option for treatment from the World Health Organization. But as alluded to, some of the challenges with our current treatment that we're using, that 5-drug combination oral therapy, although we have been fortunate and grateful to move away from injectable-based treatment, this leads to a very high pill burden. So generally over 100 tablets per week or several thousand tablets by the end of treatment. With that, there still continues to be residual toxicity, including things like significant peripheral neuropathy and blood count dyscrasias. Some of the advice and recommendations worldwide have been for using therapeutic drug monitoring to try and reduce some of this toxicity. And unfortunately, in North America, there's only really 2 labs that will do that type of testing. It's quite costly and limited access to it. As we've alluded to, because of delays in diagnosis, this leads to delays in initiation of therapy, as well as because of delayed access to some of the medications. That thereafter leads to delays in de-isolation for the patients and this huge interruption to their life. The treatment is still quite prolonged, 18 to 20 months. And then cost is a major challenge, which we'll get into here. In addition to the costs faced to a program, these are costs directly faced to the patient, including payments for different needs for services, transportation, parking, lodging, non-tuberculous medications, and childcare, and then indirect costs like lost income. This diagnosis can have a devastating impact on an individual and their family. We tried to estimate the cost of our current drug therapy recommended regimen, that 5-drug regimen that I talked about, using the Alberta Drug Depot for an average sized individual. Drug susceptible TB was estimated at about $500 or so. Multi-drug resistant TB, on the other hand, our currently recommended regimen for that 18-month period came out around $80,000. And this excludes the fact that one of the core medications of that regimen is actually compassionately supplied by the manufacturer. Otherwise, that cost would be over $130,000. This new novel shortened regimen of 6 to 9 months, estimated cost would be about $7,000 or so. But this also excludes again, the compassionate supply of one of those core medications, which would otherwise take the cost to $55,000. So certainly far more costly than drug susceptible TB, but again, another motivator for moving away from prolonged treatments at all possible. This very cool study from last year took it one step further. So in addition to the drug costs, some of the cost associated with TB care specific to Canada. So things like diagnostic testing, monitoring, inpatient, outpatient visits, amongst other things. And so latent tuberculosis infection estimate around $800 or so. Drug susceptible TB about $12,000. Isoniazid resistant, a little bit more expensive at $19,000. And then overall cost estimate of multi-drug resistant TB of about $119,000. So in relative cost considerations, multi-drug resistant TB represent about 8 times the cost of a drug susceptible TB diagnosis with the care required of it. Or alternatively, if you look at latent TB infection, you can treat about 23 people with latent TB infection for the cost of treating 1 person with drug susceptible TB, promoting the idea of TB preventive therapy for latent TB infection, amongst many other reasons for providing that intervention. And that cost difference would be vastly exponentially larger for preventive therapy provided for multi-drug resistant tuberculosis. If we look at the individual costs of tuberculosis, so this data is not specific to Canada. It's from a low-income setting in Malawi, and it's also not specific to MDR TB. And so realistically, the impact is likely to be further increased with multi-drug resistant TB. But in patients who are diagnosed and treated with further tuberculosis diagnosis and comparing the situation after the treatment, there was significantly fewer that were in paid work after the treatment. In those who had returned to work, there was a significantly lower median income, and significantly higher number were living in poverty after that treatment course. An alternative study looked at this idea of catastrophic drug costs incurred by a diagnosis of tuberculosis. And in those with drug-susceptible TB, about a third had catastrophic costs incurred on the household. In those with drug-resistant TB, that was over 81% of individuals. A huge, huge impact to a family. This idea of catastrophic drug costs, so it refers to about or over at least 20% of an annual household income being spent on medical expenditures. And if you look at this column on the right, which looks specifically at drug-resistant TB, has averaged over 75 to 80% of individuals or households, pardon me, experiencing catastrophic drug costs, with rates that have been as high as 90 to 95% in some countries. Devastating impact of this diagnosis. And so, amongst other things, I think it highlights the huge potential and transformative benefit of one thing, of moving to shorter treatment as much as possible, all oral regimens. These are associated with lower toxicity. And with that lower toxicity and more effective medications comes with higher treatment success. These regimens are cheaper, and the shorter time that someone requires to be on treatment, there's going to be less associated indirect costs, is the hope, as well as the time spent with that. Really, these new combinations do have the potential to be game changers, and it's an exciting time in TB treatment right now. So then, if we look at ideas for multi-drug-resistant TB prevention, there's certainly are certain interventions that are available to us to try and protect against this potential increase. Part of that includes assessing for drug resistance at the time of assessment with a new patient. This is something that we're, as clinicians, are doing regularly, but exploring risk factors for resistance, including prior treatment and country of origin, exposure to someone with previous TB, etc., with the idea of potentially expanding their regimen up front to avoid secondary transmission to those close contacts. We've talked about this, but improving access and utilization of drug susceptibility testing. We know from low-income countries that rapid drug susceptibility testing, that molecular testing, can reduce the risk of transmission and poor outcomes. And we know certainly it can shorten time to appropriate treatment, shorten the time required in isolation, which have direct benefits to the patient. Assessment at the time of immigration. So with the immigration medical assessment required for coming to Canada, this can represent an important time for detecting drug-resistant TB. When we looked at our data in Alberta a few years back, for the previous decade or 11 years, almost 50% of our MDR cases had been referred from Immigration Canada for medical assessment based on abnormalities on their chest X-ray or prior treatment, and 30% of those cases were diagnosed as drug-resistant TB at the time of the referral. This is an important time for making that potential diagnosis, but also connecting an individual in a new setting and with available resources if they haven't had connection otherwise. Household and close contact tracing and preventive therapy is an important intervention as well. This is well recognized as a necessity for the eventual goal of TB elimination, and MDR TB is not excluded from that. Certain types of medications called fluoroquinolones are recognized to be effective and cost-effective for preventing TB reactivation and subsequent cases down the line. Treatment support to enhance adherence and completion. Some of them, probably one of the most important, I think, prevention strategies that I can put on this slide. This is something that so many of you are doing on a daily basis, and certainly something that probably is, like I say, the most important contributor to achieving treatment success in the patients that I see in our clinic. The treatment itself, the prescription provided is such a small component of that. It's the support provided by our allied health staff, our nurses, our pharmacists, our social workers, everything to really maintain the patient engaged in care to help navigate those side effects and encourage ongoing buy-in to this diagnosis and to the treatment required. Directly observed therapy is not ubiquitously used across the country, but has been associated with higher treatment success in MDR TB, and so is an important consideration as a result. Therapeutic drug monitoring is something becoming a bit more in vogue over the past few years, really ensuring appropriate concentrations of the medication in the bloodstream of patients. And there certainly is likely a role for this in certain high-risk patients who for malabsorbing medications, individuals with gastrointestinal disease, including gastrointestinal tuberculosis, HIV, chronic liver disease, chronic kidney disease, all of which might lower the concentrations in the bloodstream, and is a valuable modality to have in our arsenal. Again, unfortunately expensive and not and can be challenging to access. National collaboration. This is such an important component for idea sharing, and is already well established by such important organizations as Stop TB Canada, and really using those resources that are available to us. And then international investment and support, which we'll get into a little bit here. So I think to kind of wrap up, what is needed, I think, for helping to stem the tide of multi-drug-resistant TB and helping to support our patients that we see on a daily basis. Sustained funding is a very big component of this. In 2021, globally, it was estimated that about $5.5 billion was spent or brought forth for TB diagnostics and treatment, which sounds like a reasonable amount of money, and yet was still a shortfall of over 50% of what was felt is likely needed to eliminate tuberculosis. And yet, if you compare that with what was spent on COVID-19, by the end of 2020, so that very first year that we saw COVID-19 throughout the world, by the end of 2020, $14 trillion had been spent on COVID-19 in some facet or another. And this is so important to recognize because for tuberculosis, international donor funding represents close to 50% of TB care in low income and high burden countries. And this includes countries where multi-drug resistance is a high challenge. And this funding is important for things like case notification, susceptibility testing, social inequity interventions. Again, improved access to susceptibility testing, both culture-based testing internationally, but also improved access to molecular testing. More multi-sectoral interventions, including financial components, transportation vouchers, reimbursement for costs incurred, food support to avoid food insecurity, social and physical support to, again, help, I guess, embrace and support our patients as they're dealing with the challenge of the diagnosis and its symptoms itself, but also some of the residual toxicity with our treatments. Universal health coverage for avoiding catastrophic drug costs. This ongoing pursuit of shorter, less toxic regimens, because the less time that someone is required for treatment and the associated toxicity and costs incurred, all can improve those facets of our treatment. We do need expedited and reliable access to novel medications, which will continue to hopefully be a collaborative intervention across the country. National collaboration with sustained, I think, governmental and clinical engagement and support with organizations such as Stop TB that have been promoting these ideas for a long time. This allows for the opportunity for further collaboration on and strategies on clinical grounds for idea sharing, drug access challenges, and how to navigate those challenges, leveraging resources are all going to be required. And then people to care, people like yourselves. This is my, I think, final editorial piece for the talk. But in my mind, COVID is the hallmark example of what can happen when those with power and money and influence are scared or politically motivated. Vaccines can be developed, approved, and distributed in a span of months. money can seemingly, trillions of dollars of money can seemingly appear out of thin air. And unfortunately, there hasn't been this sustained concern about something like tuberculosis because of that idea that it's somebody else's problem. And that's something that is a day-to-day difficulty an idea to promote to those around us and those in power. But it really comes from the hearts of those who actually who do care and see the human behind these diagnoses that we're dealing with on a daily basis. So with that, I want to thank you again very much for taking the time to join and listen in. I'll just highlight again that document on the NCCID website if you're looking for a bit more in-depth discussion about some of these areas and some of the stats behind that, which I didn't really get into today. Thanks again very much.
Thanks so much, Dr. Edwards. I just want to congratulate you. That was a really great talk. And I was first impressed by how stunning and beautiful your slides are. So thank you for putting the effort into that. But also, you covered everything from the very clinical microbiological to the international social determinants of health. And so well done for covering the broad spectrum of issues that make TB really fascinating and why a lot of us find it a great place to study and work. So I'll just wait for more questions to come in. We've already had a few really great ones and we can talk about them. But I want to just take a moment to go off script and mention your slide. One on, I just want to appreciate what you said about COVID and how COVID is an example of how we can really take action when everyone is motivated and just agree with you very much on that. And point out, I think it's a really important time when we have this audience is to point out that there's in September another meeting with the United Nations, a second United Nations high-level meeting on tuberculosis. The first was in 2018, and we're having an update in September 2023, 5 years after the first UN high-level meeting. And you pointed out that TB, multi-drug-resistant TB anywhere is multi-drug-resistant TB, and we have reason to be concerned. And countries really do lack resources to be able to deal with multi-drug-resistant tuberculosis effectively, and that is a problem for us, absolutely. So I'm going to post the link to the Stop TB Canada website because they're an advocacy organization in Canada that's working, that works hard to fight TB in Canada, and they're, lobbying our government to be more active to their commitments to the UN high-level meeting, to be active on that front. So please go to the Stop TB Canada website for more information there. So the first question that's come in is just to talk a little bit more about those short course regimens that you mentioned and how important they are. So, I think, could you share a little bit about what you know about the short course regimens that have been used in Canada so far and the advantages of those short course regimens and people's experiences?
Yeah, absolutely. So we're, as alluded to, we're literally in the evolution and development and incorporation of those. There's a lot of excitement about those. That I'm aware of. One of those regimens was first used at University of British Columbia, as far as I'm aware, in 2022, and that's based on some of the clinical trials that have been out there. It's a 3 or perhaps 4 drug regimen, kind of 2 different regimens that have been used. Within that, 2 of those still require Health Canada approval to import to the medications that are not approved in Canada. And that is probably the biggest challenge associated with using these regimens. I think right now, one of 2 challenges, I guess the other challenge being we don't have long-term outcome data for these yet, but that challenge is probably the greatest thing, just because like any new intervention, especially an intervention that's not approved in Canada, uptake is appropriately going to be slow, and figuring out the details of that is can be a challenge. We've just gone through our first process of using one of those regimens in Calgary, and we're successful in obtaining the medications, including from the manufacturer. But that whole process of applying for Health Canada approval, applying to the drug manufacturer, and another organization, the TB Consortium, for approval of one of the medications can take about 2 to 3 weeks. So off the top, you're potentially delaying a start of one of those regimens for 2 to 3 weeks, even after diagnosis is confirmed for multidrug-resistant TB. So that is a challenge. And upfront, we'll usually use a different combination of medications so that we can at least start some type of appropriate treatment. So that is where we're at. I think, it's barring major surprises in outcomes from long-term follow-up, these trials that show that they're less effective, which takes years to see if they're less effective for things like relapse. But so far, there's been no indication of that. And if they continue to be as promising than they are, they will for sure be the way of the future. Treatment shortening it as much as possible.
Great, thank you so much. So another question we've had come in a couple of different ways is latent TB treatment for contacts of MDR TB. If you can just comment a little bit on the differences between preventative treatment for people who have been in contact with someone who have multi-drug-resistant TB compared to a drug-sensitive case. And if you encountered, what communication strategies do you often use to convince people of to communicate the importance of taking this latent TB treatment, if that kind of conversation is needed?
Yeah, great question. So treatment is for latent TB, preventive therapy for multi-drug-resistant TB is a bit different. So for drug-susceptible TB is most commonly using, locally we're using a 4-month course of rifampin. Well recognized that you can use isoniazid or isoniazid and rifapentine, and those are all, by definition, if it's confirmed that it's an acquisition from an MDR case, are going to be resistant, and so need to use an alternative regimen. That regimen most commonly is something using either levofloxacin or moxifloxacin. So these fluoroquinolone medications that I recommended, not well defined, but typically 9, maybe 12 months of treatment with one of those medications, and as alluded to, seem to be fairly quite effective for prevention. Convincing is a whole conversation on its own, and can be a challenge. Certainly some individuals are very receptive to that idea. For others, that can be very difficult, and that brings to mind my own patients that have had some of these challenges. Sometimes it's returning to that human aspect of it, the experience that they've seen. Oftentimes they know who they've been exposed to potentially. They've seen the challenges that active TB disease and the treatment that's required of that, the long nature of it, the side effects that their friend or family member has been experiencing, and trying to return to some of those challenges and see it as an effective way of preventing the need for them going through it is usually my most effective strategy, along with really ongoing support and communication from our allied health staff has been the most effective for me, I find.
Great, and another question we've had come in is again about the access to some of these new second-line medications. So if you could comment a little bit on some of the access challenges, like some of the particular, the specifics of the questions are, have these medications been approved by Health Canada? And do you know if the manufacturers have sought approval? Or maybe just if you can comment a little bit more on the process of obtaining access to these medications and any strategies that have been successful that you've found in your experience.
Yeah, for sure. So big challenge for obtaining these. As mentioned, so our current recommended treatment of 5 drugs, 3 of them are not approved in Canada, and are probably unlikely to ever be approved in Canada. I mean, certainly some of them have been around for several decades, and there's so no one will be seeking drug approval for that. One of the medications, one of the newer medications that's been transformative in TB care is bedaquiline, and was approved by FDA 2014, I think, 2012 or 2014. Anyways, I mean, we're now 9 to 11 years beyond that, and there still has not been pursuit of approval in Canada. And I mean, part of that is the nature of, because we're fortunate to be a low incidence country for tuberculosis, and especially for multi-drug resistant TB comparatively to the world, there's not much impetus for many of these drug companies to pursue the approval process for Health Canada. So that's why I say that they may not. And so then it requires the special access approval application through Health Canada, which in and of itself is once you've done it once or twice, it's certainly a fairly algorithmic process. But my own personal experience, that first time applying for SAP approval, if you have no experience with it, it's a very overwhelming process. And that's where this collaborative idea of I think information sharing for how to go about this. What are the steps that need to be taken for first applying to Health Canada and then to the manufacturer? To be honest, that's how we went about our first application for one of the newer novel medications, predominant, something that we'd never sought out before and was seen to be successful in one of these clinical trials. It was really basing it on the experience provided and published by the UBC group, which helped us to know, okay, these are the steps we need to take. We're fortunate to have colleagues that we can reach out to, at those sites to help with some of those questions. And I think, expanding those information sharing, whether that be through Stop TB or some other organization through Canada, I think are ways to help clinicians who are certainly far less familiar and don't have the pharmacy resources maybe at their disposal, for example, that can be very helpful for understanding how to go about this process.
Great. Okay, thank you for that. So unfortunately, we're out of time for the webinar today, and I apologize. There's a few questions in the Q&A that we weren't able to get to, but you can feel free to email them after the fact if that's something that you'd like discussed, or go to the website. So just thank you again, Dr. Edwards, for sharing your time and experience with us today. We just really appreciate all your insights. It's very great. Thank you very much. And so as we close, just want to remind you that you'll receive a link to the evaluation for the webinar today. And please just take a moment to complete the evaluation, and that will help us going forward in our work. So thank you very much, everyone, for joining. We really appreciate your time and attention, and goodbye. Thank you.